The following is a recorded program of an actual stroke support group. The comments expressed are the personal opinions of the participants and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.
Stroke.
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 It comes out of the blue, sometimes without warning.
But those who survive it
should never lose hope.
A stroke can be life-changing.
But it is also
A new beginning.
because for all survivors, there is still a beautiful life after stroke.
Hey everybody, this is Life After Stroke. I'm Christopher Ewing. Thank you so much for tuning in. Today we're broadcasting from home base, which is Providence St. Joseph's Medical Center here in Burbank, California. And on the show today, we've got a special guest who is Megan Young. She is the supervisor of occupational therapy here at Providence St. Joseph's Medical Center. But before we get to her, as you know, we tape this at a support group that goes on at the same time. And we've got some fellow stroke survivors here who are just also great friends who we're going to go around the table and introduce them. And John says we should call them the cohorts. So we're going to introduce you to the cohorts who are here. And we'll start down here with Dave.
Hello, my name is Dave. I had a massive right frontal stroke 2 years ago.
Yep, and I told you were in trouble this week.
As always.
As always. And the reason I said you're in trouble because after last week, now for those of you who listen every week, Dave's been on the show every week, and after last week's show, we all went to lunch, and his wife met us there. And, well, your wife outed you, man. You've been holding back on us. You've been holding back on us. And I say that because Dave, and every week you've heard me say how remarkable his recovery is, with the story that he tells us about how bad it was 2 years ago and compared to how he is now. You have no idea. You did not tell us that you couldn't even swallow.
No.
Tell everyone a little bit about that.
My left side was completely paralyzed, but I couldn't swallow, and I had to learn how to eat again. But that was, through mostly ground or pureed foods, and then learned how to swallow again.
That's amazing. And how long was it until you could swallow?
About a month.
A month.
It took about a good 2 or 3 months before I could drink water.
Wow.
Yeah.
And they discovered that in the hospital. I guess
Yes.
they did like the swallowing test or whatever.
Yeah.
And so then did you just eat like stuff that was just kind of mushed up almost?
Yeah, everything was pretty much pureed or mashed.
But
ground.
Of the consistency of what?
I guess dog food.
Wow. And anything runnier than that would be
It was just
too runny, I guess.
yeah, it was just too hard to eat. I would begin to choke.
Wow. And I remember when we were at lunch last week, you were even talking about how when you did chew, you were like me, you were chewing half your face off because you were just biting yourself.
I kept on biting my cheeks and stuff. Yeah.
I remember that so well, man. My goodness. Wow. Well, man, I'm going to say it again. That your recovery is even more remarkable.
I don't think I'm anywhere near where I need to be.
I know, but I still, man, give yourself some credit, bro.
Well, I'll give myself some credit, but I need to.
You got to keep the mic so people can hear you.
Oh, I'm sorry. I'm sorry.
That's all right. So you'll give yourself some credit with, but what?
I'll give myself some credit, but I have a long ways to go.
Yeah, but man, don't be so hard on yourself because I'm telling you, you've come a long
I still need to be able to swim.
Okay. All right. And I told you, you're going to get there just
swim
because
and
you're
get
so
on a
determined.
bicycle, and then, other things.
Wow, man, I'm so happy for you, Dave.
Oh,
my goodness. Because you're just an awesome guy on top of that, and I'm
Thank
so
you.
glad to see the recovery that you made.
It's a real test of yourself, isn't it?
Sure, absolutely. Well, and and I think that's why I'm banking on you that you're going to be back swimming like a fish and everything else that you want to do because your determination is so strong. And it's carried throughout your entire story. Like, the story of how you were here in the hospital and how you'd walk the halls at night and they'd find you on the stairs, walking the stairs. All of that plays such a major role, doesn't it?
It does, but, it's that adage, that what doesn't kill us makes us stronger.
Absolutely. And I'll tell you this, and I'm sure that there's people that are listening that have, done the same thing. You personally have been such an incredible inspiration for me personally, because there's been times where I've thought, okay, I'm just going to do this. It'll be quicker to just do it with what I call my good hand, but then I think about you and it's like, just keep it moving, keep the other one moving. Absolutely. I have thought about you so many times. You have kicked me in the tail many times and you don't even realize it.
Well, I thank the people in the hospital. I mean, they were such a such a good group. I mean, I've never met so many nice people in my life.
And you were at this hospital here.
I was at
though,
this
right?
hospital, yes.
Absolutely. Well, they are great people here, and that's why we're here, because they are good people. So, yeah, absolutely. So cool. So cool. Yay.
Thank you.
Awesome, Dave. Our next friend here is...
My name is Williamson,
Yes, it is.
and I had my stroke last March, March 29, 2018. So it's about 10 months now.
Right.
And I had ischemic stroke at the basal ganglia.
Oh, I didn't know yours was in the basal ganglia, too. Full disclosure here, Williamson, I know Williamson from church. And he's just such an awesome guy. I just love this guy. And he's kind of become my little mentor of sorts, because he had his stroke a month before I had mine. So we're kind of like a little team here. We've kind of going through our stroke together almost, really.
Yes.
And but I didn't know yours was in the basal ganglia, too. Isn't that something? Yeah.
Yes.
But, man, I mean, his recovery has been remarkable, too. He actually came and visited me in the hospital when I was in the hospital. And
I went and visited you.
with Dr. Tan.
With Dr. Tan
with,
Peter.
Yes.
Because I was already recovering,
You were already
and
recovered,
I
that's
want to be
right.
there for you.
Oh, man, I do
And
recall
as
now.
they say, it takes a stroke survivor to understand a stroke survivor.
Absolutely. And I tell you, you know, through going to church, you know, every week and seeing you and, you know, comparing notes and, you know, you've educated me so much, Williamson, on just how I should do some of my own recovery and things that have worked for you. And you were the first one that mentioned to me about the importance of having a neurophysical therapist as opposed to just kind of a physical therapist. No discredit to standard physical therapists, but you know, for us stroke survivors, it really is important. And we learned this last week on last week's show when we had Chin here. It really is important to have a neurophysical therapist in our situation because, you know, we're kind of unique in our situation. I mean, we don't have a busted knee that just needs some exercise. You know, we've got kind of a busted brain that we have to kind of connect back to our knee. And so it really does take a neurophysical therapist to kind of help us kind of figure out how to channel all that back in there and stuff like that.
Yeah, that's correct.
Yeah. Well, man, I'm so glad you can make it. And next to Williamson, we have...
John. I had my stroke 3 years ago, and I'm getting better and better, but it's hard stuff.
Yeah, but you know what, man? I got to tell you, we were talking about this before we went on the air today. John, you have improved just in the time that I've known you, just from us doing the show. I'm sure people, if they listen to the shows, they can hear how much you just continue to improve. You know, it's just amazing. And I've heard other people, before I met you, people that knew you from the very beginning, they're amazed. I mean, everybody's just amazed at your recovery, you know?
Yeah. I'm getting better and better, but I was in the Army, and I spoke a lot of time, and
yeah, you
now,
were PR, you said.
I don't know. But it's getting better and better for me.
Yeah. You know, and that's kind of the tough part, you know, you guys. It's like, you know, John is referring to the fact that he was in PR when he was in the Army. And so obviously talking was part of the job.
Yes.
I mean, you know, but we really can't we can't look back and kick ourselves or be too bummed about what we don't have compared to how we were.
Yeah.
Because we're headed in that direction. You know what I mean?
Yeah. And I will ride on my motorcycle soon.
Yes, I bet.
And I'm getting there, but it's waiting for me.
Yeah, there you go. Now, you were talking about the fact that swimming has really helped you. Talk a little bit about that.
The why is good for me to swim, and Parkinson's and old age and stroke victims get in there and do it. Do it. I work out with friends, and it's fun stuff. And the teacher is good for instruction, and I am good for working out and swimming.
Right. Now, when you go there, do they have like a special program or is
Yes.
it? Oh,
Yeah.
really? Okay.
Yeah. And old age, stroke.
Really? So it's very specific to conditions, even.
Yeah,
Wow.
yeah. And it's getting better and better for me.
Mm-hmm.
And I work out at the gym as well, and not free weights. But it's getting better and better for me there too.
Awesome. Now, you were saying also that in the pool they have weights that you work with. Is that?
Yeah. And I like them a lot, and it's good for me to get out there, do that stuff.
Right. That is so awesome. And Williamson, I know one thing that you're a big advocate about is stretching, and that's what's really helped you a lot. Tell everyone a little bit about kind of what was most affected following your stroke.
Just like most stroke patients, the first several weeks, the half side of the body has been immobilized, cannot move, nothing moves, not the thumb, and so forth. So slowly everything recovered. But one of the things that I kept learning through the process is that it is the brain and not the arms or legs, as most people would think that friends or relatives who came would say, oh, exercise your legs, exercise your arm. It's the brain. So it's important for the eyes to look at the arm and the leg and say, I want to move them. And in doing so, we're letting the brain generate the cells and nerves to connect with the arms and leg. So constantly doing something. So in my case, I think aside from the physical therapy and occupational therapy, I created projects at home that I wanted to do. Small projects, like even picking up a grape to eat. It is a project, and forcing the fingers to pluck a grape and reaching for the grape, putting it into the mouth. All of these are goals that we want to achieve. So in my case, I have told my therapists that my long-term 6 months goal, if possible, is to go back to deep sea fishing.
Yeah.
And having that goal, you have to walk, you have to balance, you have to get your arms cranking in order to fight with the fish. So that goals allowed me to have some specific goals. So I'm not totally 100% normal, but those goals allow major muscles to be moving because I have a goal.
Absolutely. And I've said this to you several times, and I'll say it publicly now. One of the things that really has been so helpful to me is connecting with you at church when we talk after church, and you telling me some of the exercises that you've done, or some of the things that, hey, be sure to keep doing this. You have just been such an encouragement to me, Williamson, and I've said that to you so many times, but I'm so glad you're here on the show today, because I hope people get as much encouragement from you as I've gotten from you over the past few months, because, you're another one, just like Dave. It's like I play back in my head some of the things that you've said, and I think that's why it's so important that we do stuff like this, because we're all in this together, and we kind of learn from each other. It's kind of like, hey, here's something that I learned from my therapist, or here's something that I I'm doing at home that's kind of working for me. It's like we just kind of learn from each other, and I've just learned so much from you, man, and it's just so great to hear even what you just said now. And I asked you this before, so I don't mean to put you on the spot, but you made this awesome video that you showed during Thanksgiving at the Thanksgiving service at church, and I'd asked you if I could take that video and put it on the strokechannel.tv website. Can I do that?
Sure.
That everybody listening, Williams made a video. They played it during the Thanksgiving service at church, and I'm getting a little emotional thinking about it now, because it got me really emotional when they played it in church. It was almost, and I'm going to have to ask one of the doctors about this, because it was really it was like a PTSD moment for me. In one of the shots, they showed you in the wheelchair, and you had your gait belt on, and they were helping you out. And I just remember man, it just hit me like a ton of bricks, and I just started bawling. It just brought back just a really, not a bad memory, but a sad memory of just the helplessness that I recall feeling when I, was in a wheelchair, couldn't walk, had the gait belt and everything, and I guess my point is that the video, it's not sad. It's so awesome because you show, and it's actually funny in some places as I think about it now, but it's amazing how you've chronicled the progress that you've made from the beginning to now. I mean, you're fighting with the fish. It's really awesome. And so thank you for letting me put it on the website. When you guys hear this, it'll probably be on because, it takes a couple days to take the show and put it, get it on air and everything like that. But, when you see the video, it's really, really cool. And it's just a really great representation of the progress that we can all make. If we just, like you said, be very determined and just work really hard, that you set a goal for yourself,
Mm-hmm. Yeah. Thank you, Chris.
Oh, please.
Yeah. That video, I remember it. I started recording on day 3 of my stroke.
Mm-hmm.
I had my stroke on March 29. And even though I had very little knowledge of stroke at that time, but realizing half the body cannot function, and I said, Lord, if I have to go through this journey, make this journey blessings to others. I'm thankful that we have smartphone these days. So I start recording myself, selfie, everything in the video. Even at night when I notice that the arms can suddenly move by itself if I look at it and commanded it to move. Very difficult, but it takes 1 minute to move a thumb.
Sure.
But at least it starts moving. I recorded that first movement, and thereafter all the little therapies, everything. So after 10 months, you see the progress from being immobilized to the time I went back to the deep sea out by Channel Islands, deep sea fishing.
Really amazing. When you were fighting with that fish and trying to get it in the boat, and I was like, wow, man, look at you. I mean, you're twirling and pulling. That was a big fight. It was a big deal.
Yeah.
That's so awesome. So awesome. Well, we're going to take a quick break, and when we come back, we will have our special guest, who is Megan Young. She is the supervisor of occupational therapy here at Providence St. Joseph's Medical Center. So sit tight, and we'll be right back. Hey everybody, welcome back to Life After Stroke. I'm Christopher Ewing, and with us right now is our special guest today. It is Megan Young. She is a supervisor of occupational therapy here at Providence St. Joseph's Medical Center. Thank you so much for coming.
Yes, thank you for having me.
Why don't you tell everyone a little bit about your background and stuff like that?
Sure. So I attended the University of Southern California for my occupational therapy degree. Soon after I graduated school, I actually started off in pediatrics. So I started working in an outpatient clinic, working a lot with kids with autism, speech delay, developmental delay. And after about 3 years, I felt that I had kind of a desire to serve a different population, especially with like my grandparents at the time having more medical problems. And so I decided to make the transition to work with the adult population, and I found my job here at Providence St. Joseph's back in 2013, and I've been here ever since.
So awesome. Good for you. One of the questions I have is, I've noticed that when we're brought in as stroke patients, stroke survivors, kind of the first thing that happens is you guys make us hit the ground running. Like as soon as the clot's taken out or the bleeding has stopped, we get put right to work in terms of getting therapy right away. Why is that?
Well, as we learn these days, like especially in school or just in the literature, trying to get moving or starting therapy as soon as possible once medically cleared by the doctors, that is really important right now, especially with stroke. There's critical times in the first few months that you want to try to be aggressive with therapy as the patient can tolerate. And so the goal is to try to see what can be returned in that amount of time.
And it just seems like that there is no rest for the weary. I mean, we're still kind of just recovering from the stroke just within the past couple of days, and we're put right to work in terms of trying to get things to move and function and stuff like that. So really, it's that crucial, that kind of immediacy, huh?
Yes, and in the hospital setting, because we call this setting the acute care. It happened in the acute phase where soon after you had the stroke. And so a lot of people may not be completely aware of what's going on, or they just don't have any motivation to move because they know they can't move one side of their body. So in the hospital setting, it may not be like getting up and running around, and it could be simple as getting them to be able to sit up so that they can brush their teeth, or sit up and be able to sit on their own, working on sitting balance, or even just being able to remain awake to participate in a simple activity.
Right. And as an occupational therapist, I know that, from what I've heard, it's kind of like occupational therapy is above the waist and physical therapy is below the waist kind of thing. Like, that's kind of the departments that I guess the therapists kind of take. What are some of the things that an occupational therapist focuses on? What kind of falls under your umbrella of therapy?
Yeah, so I think the traditional explanation of the two therapies is, yes, the upper half is occupational therapy, the lower half is physical therapy. But I like to take a look at it. It's very interwoven. Our body is not necessarily working. The upper body works by itself and the lower body works by itself. The body needs to work together. Yes, we do focus a lot more on the upper extremities, the arms, but the way I like to explain what occupational therapy focuses on is it focuses on, yes, you being able to move, but being able to move to participate in your basic everyday self-care or any activities that would be meaningful to the person.
Now, there's this window of time that's often talked about, like the 3 months is when you get a lot of stuff back because of neuroplasticity, and then 6 months, there's like this little plateau, and then after 1 year, well, that's pretty much what you got. That's your quote-unquote new normal. Is that kind of a time frame that you embrace, or have you seen people progress much more beyond that quote-unquote window of time?
I always say you can never say always or never, because with anything going on with our brain, it's so complex that I can never say, like, after a year, this is how you're going to look. In my experience, just because I'm in the hospital, I unfortunately don't get to see people kind of at your stages of recovery, so I don't have much experience seeing how much recovery people get. So whenever I do get to encounter people at this stage, it's very interesting for me, because a lot of times in the stages I see people, they require like 2 people to get them up, or they can't attend to like one side, so they call it neglect, where they can't even look to the other side, or like some of you said that one of your or half your body you couldn't move in the beginning. So a lot of the types of patients I see in the beginning, and then I also see them in our acute rehab phase too. So it's interesting to see some people get return back even after, start to get some minimal return after a few weeks here. But I do remember a patient that I kind of saw in the hospital setting. He was in our rehab, and when I was doing home health, I actually had him as a patient. And when he was I think that was maybe a few months after, when he was in the hospital, he couldn't move half his body. He could barely sit up or barely get out of bed. And when I went to go see him for home health, he was able to get up, transfer to his motorized scooter on his own. His arm that was not moving here, he almost had full range of motion, and we were working on like hand grip. So, the timetable varies. Right. Unfortunately, I know people like to hear a cookie cutter answer, like as if they broke their arm, 6
weeks later. Yeah.
Correct. And so when I see patients, I kind of give that analogy, like it's not the same thing as if you broke a bone. So it's hard to give you a clear set answer.
Right. Yeah, I referred earlier when we went to lunch last week, and your wife was saying how much return you've gotten after that 1 year period. You know, like that 1 year mark, it wasn't, you weren't nearly as...
Yeah, I wasn't impressed at all.
So a lot of your return has come back after that 1 year period,
After the 1 year, yes.
That's amazing.
With the Tai Chi and the yoga and the water aerobics, yes. That's really, really helped.
And we've got listeners all over the world that are listening to us at all various stages of stroke. Some are new to the game, some are post-stroke, maybe 10, 20 years. But I think it's really interesting what you're saying is that even early on, for those of you who are, maybe even listening to this while you're in the hospital, for goodness sakes, your recommendation, I guess, in that respect, Megan, is to just be prepared to just go right at it, working at it.
Yeah, I mean, in the beginning stages, I think the biggest thing is not refusing therapy when they come. It's different if they can't stay awake or if they're not really aware of what's going on. But if you are aware of what your circumstance is, or that you've had a stroke, the best thing you can do is just agree to work with the therapist when they come. Right.
Now, that brings up an interesting point. I remember being in rehab at the rehab hospital, and I remember one of the therapists, I think it was my OT, who said, I can keep you longer today if you want, because one of my other patients doesn't want to work today. And I remember thinking, well, that's kind of odd. Why would you not want to, you're here in the hospital. Why would you not want to do the therapy to, get better and get out of here? Does that happen?
Yes, that actually happens more often than you probably think.
Really?
I think in the beginning stages, it has a lot to do with one just kind of processing what's going on, coping, especially if they are aware, they completely understand what happened, and they know that they can't move one side, especially if the patient was completely independent before. They can get very down and not want to do anything, even though their mind may know that the only way to get better is they have to move and have to participate. So it's like, it's not only the physical battle, but it's also a mental and emotional battle as well.
Sure. And is that something that you find that you have to deal with, work on their emotional end of doing some of the occupational therapy?
Oh, yes, correct. And then we often have to deal with also, when family members are present, they just want to be, they want to be the motivation. They want to urge the patient to just do something. And sometimes it's like a fine balance between the patient getting a lot of stimulation from, like, you need to do this, or the patient just having the self-motivation to attempt or even try.
Do you sometimes have to work with the parents or the loved ones, I'll say, to kind of educate them as to things that may need to happen, in the transition from hospital to home?
Oh, yes, that's a huge aspect of what we do as well. Even if the patient doesn't go home straight from the hospital setting, and they go to a facility for further rehab, a big part of the recovery is also going to be what they do in the times outside of therapy. Because even if they go to like a intensive program, that's only like a few hours a day, and there's 24 hours in a day minus the time you sleep. But the more you can do on your own for the carryover will help with the recovery that we find. So part of what we do also, if it's like range of motion, exercises, then if there's a family member or a friend present that's going to be there frequently, then we involve them, we train them, show them what to do or how often, and then also ways to basically try to encourage the patient to participate in these when they're not doing any type of therapy.
Boy, this is such a vital moment that you come into the picture. You know what I mean? It's kind of like you're one of the first ones that we see is throwing us a lifeline to try to get some type of normalcy back in our life and back in our brains. I mean, because it's all been such a traumatic moment and a traumatic few days and a few weeks that we're kind of like, what the heck just happened here? I have to ask you this: how cool is it and how rewarding is it for you to see some of your patients get back some of the return as you see things start to come back online?
Oh, it's like, I mean, you can't really describe it sometimes. I mean, like, it can be a slow process, but when even you see like a little twitch in one of the fingers or in the shoulder, it just shows that, you know, something is working. You know, we're not just here, doing stuff with you. You know, it's actually causing an effect or an impact. And it's not only just how it makes me feel, but when the patient sees, or, you know, they're able to see something move, it just, seeing the smile on the patient or just the reaction, that's also a big deal.
You brought it back, girl. You're responsible for helping us get that back. And, you know, I won't get back on my soapbox, but I mean, I'll throw some love your way, as I do all you guys when you come on the show. Thank you. The role that you play in helping us get our lives back just cannot be understated. I mean, it's just, you play such a vital part in helping us become who we were, you know what I mean, in helping us get our lives back. So I just thank you for that. It's just, wow, so heavy. You know, we're going to take a break, and when we come back, Megan's going to not just tell us some of the steps that we can take at home in terms of getting back some return and to keep range of motion and things like that, but she's going to give us a little bit of homework, things that we can do to try to stay strong, get things stronger again, and all that kind of stuff. So sit tight, and we'll be right back. Hey everybody, welcome back to Life After Stroke. I'm Christopher Ewing, and we've got a question and or comment here.
I have to say, I have a comment regarding comment that the first few weeks after stroke to get the patients moving as much as possible. And coming from an Asian background, I just want to let all other listeners understand that it is predominant among Asians, among Asian cultures, to not let the patient move, because the misconception is they're sick, they need to rest. So they would say, don't move, don't do this, don't do that, rest.
Wow.
Instead of motivating people to move, they are motivating people not to move. That's the opposite. So while we have this session, just want to let everybody know, when you have a stroke, it's the opposite. You need to be up and moving.
And that's something that is throughout the Asian culture,
very popular,
regardless as to whatever
Asian
your
culture.
Illness is, no matter what it is.
Especially in the Asian,
well, I mean, even
Southeast Asian or Asian areas. Very common.
But I mean, even if you're having a stroke, they say just lay still.
That's right. Yeah. All my friends, even in America, who came to visit me and saw me moving around, they would come, no, don't. You need to be sitting down. You need to be resting.
Well, you know, before we went on the air today, you brought up something that was really interesting. You had some visitors that were in from out of town, and you said that they were carrying around
blood thinner in the pockets.
Yeah.
Because their siblings have stroke. So if their siblings have stroke, the misconception is then they are also probably going to have a stroke. So they've got this pill ready, pills in the purse, and their wallet,
even though they might have a hemorrhagic stroke.
And they're perfectly healthy people carrying this type of thing in their wallet, thinking that if they have a symptom of stroke, they're going to take the blood thinner.
And you told them, no.
Learning from the neurologist that's a misconception.
Yes. And Dr. Darflinger's over here, and he's
Yeah, I think that's a very scary idea.
Oh gosh.
You know, about 15% of these strokes are hemorrhagic, and if you take a blood thinner, that could be catastrophic.
Right.
But I did just kind of want to add the physical therapy. I think of it like kind of like the old Chicago politics. You know, vote early, vote often. And that's really what we found, and what the literature suggests: exercise early, exercise often. And I think there's a lot of research going into that end of this process now that is going to show even more improvement.
Right. And Doc, has research shown, because I was really surprised that when I was in intensive care at Cedars-Sinai, and they were like, okay, well, we're going to transfer you to a rehab hospital now. And so I was in intensive care for 5 days, and boom, I'm put to work, like boots on the ground, like instantly. And I was so surprised. I mean, I was I was glad. I mean, I was like, okay, yeah, because I'm going to get back. I got stuff to do, you know. But I was really surprised that you guys put people back to work that quickly, you know, and that instantly, and how important
Absolutely.
that is.
That seems to be what the research has pretty well suggested to us. And I think, as Megan was saying, you know, even these rehab facilities, you kind of, depending on insurance and where you go, you only have a couple hours a day throughout.
Right.
So the family is absolutely instrumental in being part of this. And as you and I have talked about before, these are things that don't just happen to the patient that had the stroke. It really, it's
the entire
a family and
Sure.
And a community thing. So
Right. And, you know, Megan, that kind of brings me to my next question is, what are some of the things that, I mean, I guess we'll start from the caregiver standpoint. What is it that some of the caregivers should kind of be aware of and looking for, and as they bring their loved one home and have to kind of help them?
I think there's a couple things. Kind of like what was mentioned prior was like, you know, in the Asian culture. I think as a therapist, we deal with many people from many different backgrounds. And so, again, going back to the education point, that's a big part, especially in the beginning, is just to try to help the family understand, because a tendency is also not only will they say don't move, but then they want to do everything for the patient. Whereas from a therapy standpoint, you don't want to do everything for the patient. You want to give them an opportunity to try to do something for themselves, try to get that arm moving, try to get the leg moving, because we also don't want them to become dependent on the person. And it may be as a simple thing as them being able to respond for themselves. And so that's one point. And then now progress to the stage where you're going to be going home. A lot of things that an occupational therapist may address, not only is like the home exercise program, but more so home safety at home. You know, if you're going to need modifications to how you get into your tub or your shower, like repositioning things, or if you're going to need, say your balance isn't 100% yet, are you going to need some type of chair or medical equipment to keep you safe when you do a shower? I think it's also just kind of, again, educating whoever's going to be with the person majority of the time. It's a lot. The first transition is going to be about safety. So, you know, it could vary. The patient may not be yet able to walk completely on their own, like all of you are here today. So they may need to be by the person's side when they're walking or getting dressed. For me, as an occupational therapist, a big area will be mostly like the bathroom, because everyone has to eventually go to the bathroom or they shower. They want to shower. So that's a big area we focus on, you know, use of grab bars or use of a type of chair to keep you safe, because you got the water involved. You don't want to slip and have a fall inside and kind of set your recovery back.
And what are some of the things that a caregiver maybe should work with their loved one at home? Is there any kind of exercises that they should help them with and things like that?
Well, if we're talking specifically about, I guess, more the arms, I think it really depends on how much return the person has as far as being able to lift their arm up or out to the side. Kind of like the physical therapist you had last time was emphasizing, was we want to make sure you have your range of motion. Your range of motion is basically your movement. You know, being able to lift your arm above your head without... Also, I think a key thing is also being able to move your arm without doing any compensation. So, like, some people may be able to lift their arm, but they're leaning completely to one side to be able to get it above their head. So, also trying to move, quote unquote, as, I guess, you know, normal versus trying to lean over to just get it above your head.
Right.
So, definitely being able to show the family member ways to encourage the movement. Some people can't do it on their own, so we show them ways to assist the person moving it up and down, out to the side, and we focus on all the joints in the arm. So like the shoulder, the elbow, the hand, the wrist, the fingers. And the goal is, if depending on what movement they have, you want to try to have the person with the stroke to try to do as much as they can, and then the family member can help assist like the rest of the range of motion, if that makes sense.
Absolutely. Now, what if the patient has to deal with things like numbness, pain, things like that? Because I know that that's something that tends to be fairly common, is like the tingling sensation, maybe nerves aren't completely back online and things like that. What can they do to try to get some of that to kind of chill out and feel more normal and less numb and less on fire and things like that?
I don't think there's like a set one answer. I think it's very dependent on the individual and what type of numbness or what works for them, because one thing may not work for the other person. Sometimes the big thing that we do tell people, especially with numbness, because they may not feel that well on that side, so you really want to be aware of what you're doing with, say, that hand or that arm. You don't want it to be bumping into things. You want to be checking your skin in case like you get a cut or a bruise that you may not be aware of. Sometimes we'll say you can try compression. So compression is, basically like wearing a sleeve. Sometimes that helps. And again, it's not the same thing across all boards for each person, unfortunately.
Right. We're in our kind of final minutes here, but I want to ask you to give us a little bit of homework, if you will. What should a stroke survivor do in terms of trying to maintain their own range of motion? What kind of exercises should they be doing?
Well, I think one thing is you can compare the side that's not affected to kind of see what your normal movement is. Everyone's normal movement is different. And then you can try to mimic that with the other side, whether you say your right arm is the one that's affected. Whether you use your left hand to help move that right arm into those motions, you can clasp them together. You can modify by doing things laying down. Sometimes that helps eliminate gravity. And not only on top of the range of motion, being able to move the arm, I think the biggest thing is also trying to incorporate doing the same movements with an actual activity. So like a lot of occupational therapists, yes, we do exercise, we do, things where you're just moving, but we bring it back to what we call an activity, an occupation. Whether it's something you wanted to get back to doing, kind of like you were, Williamson, correct? You were mentioning earlier that now you're able to write, you're able to do the Chinese stainless steel balls. So it's not only working on the same movements, but actually doing the activity you're hoping to get back to.
Oh, that's a good point. Absolutely. What do you think of constraint therapy, where you kind of take what they consider the good hand or the good arm, take it offline and really force yourself to use the affected arm and hand? According to the literature, constraint-induced therapy, for it to be considered constraint-induced therapy, it actually would require doing a numerous amount of hours of that versus like just 30 minutes. I see.
We encourage that you try to use the hand as much as possible, but it also don't necessarily want to try to use it let me rephrase that. Because sometimes what I encounter patients, their non-dominant hand is not affected, or they're like, oh, I can do everything with the left hand. So we definitely do not encourage just relying on the hand that's not affected. But again, I personally bring it back to try to use it when you do activities that require both hands. If you're wanting to try to do everything with that affected hand and you're not going to frustrate yourself to the point where you're not going to try it ever again, I think it depends on the person. So like if you want to try it all, try to do everything with that side, go for it.
Right.
And it's a fine line. Some people, the frustration aspect is a big thing in the beginning too, or even in any stage of recovery, because the patient wants to go back to being quote unquote, their normal. And so I think it's a good thing to encourage,
And mirror therapy, I know that they use a lot of that in occupational therapy. How have you seen that to be effective?
Yeah, so a lot of our occupational therapists here actually use mirror therapy in our rehab program. So mirror therapy is basically you're using the mirror as you move the unaffected side. You're doing movements so that you can visually see a hand moving, but because of the mirror, it's placed in the middle. It looks like the affected side is moving. So it's kind of like sending... I guess the best way...
Tricking the brain a little bit,
I was going to say the best way to explain is what you're seeing is trying to trick the brain that this side is moving. And with mirror therapy, a big success rate or just with the patient is also the carryover. It's like you show them what to do, but it does require repetition of doing it and doing it for a while versus just like 10 minutes a day.
And how much time would you need to do it in order for it to kind of be effective?
I think it's dependent on the person, because with mirror therapy, it's definitely has a big mental component, because if the patient's just sitting there and they get frustrated because they don't feel anything moving or they don't feel like anything's getting done or anything's changing, I wouldn't say that they need to do it like 30 minutes every few hours. It would be, and mirror therapy may not apply to every patient either.
Did you have a question, Williamson?
Yes, I just want to ask Megan that for those of us who had deficit on our dominant hand, so we have very strong motivation to do things with our right hand. But what would you say to those people who had deficit on their non-dominant hand, where they don't need they don't really need the left hand to do much because the right hand can do a lot of things already. So what would you say to those type of situation to motivate the non-dominant hand to be up and doing?
Well, it's a good question, because it'd be very easy for them to just say, you know what, who cares? I got my good hand.
We actually see that happen a lot. One thing that, as therapists, as we try to do is, we wouldn't necessarily do something where they can just use their dominant hand. Like, we wouldn't try to have them right. We would try to focus on activities that require use of both hands so that it's kind of they're forced to try to use it. And another component too is sometimes because their dominant hand's not affected, they might develop what we call as a learned non-use of that side. And that's where family members also play a crucial role, because if they're noticing, because the patient may not be noticing that they're not even paying attention or trying to use that other side. And so we train or educate family members, when you see that, point it out to them. And be that resource to try to get them moving that side.
So catch them and say, hey, you're using your non-affected hand a lot more than you're using your affected hand, and you're having it do a lot of the work of the affected hand, when really start putting that other hand to work a little bit more.
Yeah, I would encourage just kind of giving things that require both hands, because especially in the early stages, it's sometimes hard to remember everything because there's so much coming at the person. And so at least in occupational therapy, we would probably focus on activities or things to do with both hands, so it's bringing attention to that side versus just telling them, because sometimes people don't necessarily remember or learn best from just hearing. It's by doing.
John's got a question.
Now, my right hand was my hand, but now it's not working. But my left hand is getting stronger and stronger, and I shoot left-handed now, and I am an NRA instructor for Boy Scouts now, and left-handed, and it's good stuff. But
And were you right-handed before?
oh
though?
yes, oh yeah,
Like-
I was, but oh well. But I'm getting better and better at this stuff. But the arm is not good enough yet. But I'm getting the VA to help me for it too.
You know, that's a question, Megan. It's like, what can someone do who maybe is post-stroke a year, 2 years, maybe 3 years, who, you know, they've kind of given up a little bit. It's like, you know what? I got my other hand going good. You know, I've got this figured out. I'll be okay. What can they do to kind of, you know, get back on track and wake up that affected limb and kind of get it back online?
Yeah. I mean, unfortunately, you know, I can't necessarily speak on the best practices just because of the setting I'm in, but I can speak on just what I personally feel. I mean, I feel it again. It's all recoveries are going to be very catered to the individual, and kind of like John said, you know, he was right hand dominant, and the return is just not coming back to the point where he can use the right hand as his dominant hand right now. And so in his case, he had to basically change his dominant hand to his left hand, and he's become very functioning. And right now in his stage, that's what is working. And again, unfortunately I can't say like if the right hand's gonna ever come back fully. I think that's a big aspect too, is the emotional and mental point of the recovery. You know, each individual has their personal goal, and it's about also how to cope with that if it doesn't meet their standards. In his case, you know, he would probably like his right hand to be 100%, but he has made the decision to still live his life, and he learned to do many things with that left side.
And made some wonderful workarounds, and has it working? Yeah, absolutely.
I mean, again, even if you don't get 100% movement back in the affected limb, I think just focusing on trying to do range of motion, whether it be using that other side to help move it around. We call that passive range of motion. Just kind of giving stimulation to that side. That's just important for also, I think that can aid in pain management. You know, you don't want to keep, say you can't move your right arm. You don't want to keep the right arm in one position, because then you're going to start developing limitations. You might develop more pain. It might throw off other parts of the body just because of the way it's positioned.
Well, we're going to take another break. I know we've got some questions here and stuff like that, so everybody sit tight and we'll be right back. Hey, this is Christopher Ewing with a Life After Stroke health tip. So if you're a stroke survivor, then I'm sure you know the exact date that you had your stroke, maybe even right down to the exact hour and minute. We're often asked by doctors, therapists, and even loved ones, so when did you have your stroke? So that makes the date kind of hard to forget. But do you know the date when you started to show signs of recovery? Like when you were first able to move your leg again or your arm? The times when your brain and body start to show signs of improvement following a stroke are even more important than the day you had your stroke, because these are the times when your body is showing you signs that it is actually healing. And it is also a sign that all of your hard work and therapy is paying off. And those times should be celebrated. I call these moments milestones, and one thing I do that I'd like for you to do is to have a milestone journal where you keep track of all the breakthroughs that happen along your journey towards recovery. For instance, in my milestone journal, while it says April 21st, 2018 is when I had my stroke, I can see that it was May 4th, 2018 when my ankle first started to move again, May 9th when I could close my fingers for the first time, May 23rd, when I was able to take a few steps on my own unassisted as I was learning to walk again, and so on. It's very easy for us to remember the one terrible day that we had our stroke, but what about all of the awesome days when we noticed signs that we were actually healing and getting better? So here's what I'd like you to do. Just get a notebook, or I happen to use the Notes app on my phone, and whenever you make a special accomplishment in your recovery, just jot it down, making note of the date, the time, where you were, who was with you, and anything else you want to make note of about that special moment. It's really cool to every now and then just look back and read about some of the breakthroughs or the milestones that you have reached on your road towards recovery from your stroke. We can spend time being bummed about the loss of ability, or we can spend time celebrating the recovery of those abilities as they happen. I say, let's celebrate our recovery and all of the milestones along the way. And if you have a recovery milestone, write us and tell us about it. Just send me an email to mail@thestrokechannel.tv. That's mail@thestrokechannel.tv. And congratulations on your milestones. I'm Christopher Ewing, and this has been a Life After Stroke Health Tip. Megan, are there any toys that we should keep in our arsenal of things to exercise with, like balls, clay, things like that?
I think, again, it depends on what you're trying to work on. You know, it seems like a lot of people want to, if they have problems with their hand, they want to know what to do with the hand. I mean, yeah, you can use stress balls, you can use clay. I like to also kind of think about like what things you have in the home, because I don't necessarily want people to just go out and buy a bunch of stuff and then end up not using it. So, because we deal with people who also have like financial restrictions as well. So it's about also being resourceful. So, you know, say you don't have a stress ball, you don't have clay, you can just roll up a towel, or you can roll up socks, make it into a ball so it's soft enough and you can work on the hand grip. One thing I emphasize to people, not only do you want to work on, say, gripping, but you want to work on opening the hand too. So each motion, each movement in our limbs, we have basically two movements, like you open your clothes or you bend and you straighten the arm out. So it's not only focusing on just one thing, it's also doing both aspects of the movement as well.
What's a good trick to try to get your hand to open?
One thing, especially if there's, say, tightness in the hand because of the muscle tone, if it's so severe where you can't open, one thing you really want to make sure is that you have something soft, per se, placed in the middle, because you want to just make sure your skin's also staying intact and your nails aren't digging in.
Sure.
If it's to the point where you can slowly open the hand to the point where you can see your palm, you can always use the table surface. You can stand up and kind of put some weight on the hand to try to see if that can help stretch it out. If the table surface is too hard, you can always put like a pillow or something soft on it as well. That's one simple thing that you don't need. You just need a surface for that.
So, final thoughts.
I think, well, thank you for having me again.
Thanks for being here.
I think the biggest thing I can encourage people to do is, one thing is, yes, you know, family members can help you with the cover. They play a huge role, but also a big part too is, you know, as long as people's judgment wasn't impacted, you know, self-motivation is a big part of the recovery process. And I think it's also focusing on the actual process and the little things, because it may, for some people, the changes may not be drastic. And so for some people, it can be very discouraging in a sense. I think focusing on little things that will help you get through the recovery. And then also, just from an occupational therapist standpoint, it's also focusing on things that are meaningful to the patient. You know, you don't necessarily want to just take them through something like just stacking cones, but you can do stacking cones, but you want to incorporate what is the functional aspect of doing that. So at least in the hospital setting, we focus a lot on the self-care. So like being able to dress themselves, brush their teeth, feed themselves, because
and probably asking the patient or the stroke survivor, what will they be doing when they get home? Will they have to help change the baby? Will they have to take out the trash or whatever? Preparing them for those transitions.
Yeah. And so in the beginning stages, we want to try to focus on the basic life skills, because before any injury or any trauma, being able to just do our everyday activities, it's so second nature. But then when some life change happens, that's when you realize you may need retraining in that aspect. And that's why in the hospital setting, that's a big part of what we focus on. Because if they can't take care of or if they can't do certain things, then that's where we would make our recommendations on they would need further rehab, or we would need to train the family member in on how to assist them safely so that they don't fall, or things like that.
Right. So, boy, the decisions you make on our behalf at that point and the assessments that you make on us at that point are very, very important.
Yeah, and it's a collaborative approach. It's a lot of the like physical therapy, occupational therapy, speech therapy, the team of doctors, because a lot of times our people with strokes will have more than one doctor following them. So it's a it's a collaborative approach of everyone's perspective. Definitely.
And then knowing what their lifestyle is once they leave and go back home. What does home mean? Do you have steps to climb? Do you have a lot of drawers and doors to open and things like that, huh?
Definitely, yes.
Well, thank you so much for coming on the show. It has just
You're
been
welcome.
awesome to talk to you. We've been speaking with Megan Young. She is the supervisor of occupational therapy here at Providence St. Joseph's Medical Center. And everybody listening, we're just really rooting for all of you in your rehabilitation and your recovery. This is your stroke support group, so it's just like you're here with us. I know that we've got just tons and tons of listeners all around the world, so whether you're sitting here in the room with us or if you're sitting at home listening to us wherever you're at, just know that we are here for you and we're rooting for you and encouraging you every single step of the way. Megan, thank you so much for what you do. Thank you very much.
Yes, thank you.
For everybody listening, thank you very much for listening. And until next time, remember, there's still a beautiful life after stroke. This has been a recorded program of an actual stroke support group. The comments expressed are the opinions of the participants and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.